Good morning, fourth grade students. My third and last lecture with you will be about Anchorage. So to start with, we need to understand what the term anchorage means. In English, anchorage means the act of dropping an anchor. This is an anchor, which is a device that is usually made of metal and can be attached to a ship or boat by cable or chain. When lowered to the seabed, it helps to hold the ship in place. Now, how can this be related to orthodontics? We all know that movement of teeth occurs through the application of forces, and in order to make a change in tooth position, adequate support or anchorage must be available from which to apply these forces. So we need the structures from which we derive the force be stable, it shouldn't move. Especially when we know that this support can be derived from multiple structures including teeth, which can move. So the forces that are used to move teeth act reciprocally on the teeth that are intended for movement and upon the structures that are used for support. So there is an action and reaction, which means that we are dealing according to Newton's third law of motion, which states that for each action there is a reaction that is equal in magnitude, opposite in direction, and on the same line of action, which remains the basis of all orthodontic tooth movement. To understand that, we need to go to some basic information. So this man is trying to push a rock. His feet exert force on the ground. At the same time, there is a reactive force from the ground to his feet, and he's pushing the rock with his hands. So his hands exert force on the rock, and there is a reactive force that is equal in magnitude but opposite in direction to his hands. It's only when he has adequate support that he can exert force large enough to push the rock. Now let's have a look on these two players on skateboards. They are trying to push each other, but since both of them are standing on a skateboard, there is no stable support for either of them. When they push each other, both of them move away from each other. Now, this is similar to the condition when we use teeth as supporting structures. So the teeth are not fixed to the jaw bones. They can move. So there may be unintentional or adverse changes in the anchorage support. However, the extent of these changes depend on several factors, as we will explain later. Anchorage can be defined as the site of delivery from which a force is exerted. Others defined it as the resistance to reaction forces that is usually provided by other teeth, occasionally by the palate, sometimes by the head or neck, and by anchors screwed to the jaws. Anchorage can be classified several ways according to the site where the anchorage unit into intraoral and extraoral, according to the jaws involved, either single jaw as intramaxillary or both jaws intermaxillary, according to the manner or way of force application as simple anchorage, stationary anchorage, reciprocal anchorage, and finally according to space requirements into maximum anchorage or type A, moderate anchorage type B, and minimum anchorage type C. Intraoral anchorage is said to exist when all the anchorage units are present within the oral cavity. So the support from all intraoral sources of anchorage, including teeth, palate, etc., can form part of this type of anchorage. We can see that in the above photo, we are attracting the canines in the maxilla and mandible against the other teeth, while on the below photo it shows what's known as the pendulum appliance that is used to distalize the molars. It has an acrylic button that is resting on the palate and also support on the other teeth just to provide adequate anchorage to push the molars distally. The intraoral anchorage can be either intramaxillary, when the anchorage is within the same arch as in the above photo, or it can be intermaxillary between arches, like in the carrier system in the lower photo, where the class 3 elastics extend from the upper molars to the lower canine. Simple anchorage is said to exist when the application of force tends to change the axial inclination of the tooth or teeth that form the anchorage unit and the plane of space in which the force is being applied. So we are using the resistance of tipping of the anchoring unit to hold them in place. Since the force required for tipping is not high, it is better to engage greater number of teeth in the anchor unit than the teeth that are to be moved to ensure that the anchoring teeth will remain in their position. Stationary anchorage is said to exist when the application of force tends to displace the anchorage units bodily in the plane of space in which the force is being applied. The anchorage potential of teeth being moved bodily is considerably greater as compared to the teeth being tipped. Stationary anchorage is not possible to be obtained with removable appliance, but we can, with some bends in the wires and fixed appliance, we can have some stationary anchorage, like this bend in the wire where the second molars are tipped distally. This will make them more resistant to mesial tipping, and they will have to move bodily. Reciprocal anchorage is said to exist when two teeth or two sets of teeth move to an equal extent in an opposite direction. So the effect of the forces exerted is equal, and we can see that with median diastema closure using power chain or with a Hyrex for bilateral expansion of the maxillary arch. According to the space requirement, we have either maximum anchorage or type A anchorage. In this type, the anchor units shouldn't move, or at least must not move more than 1/3 the available space. While in moderate anchorage, type B anchorage, about half the space available is utilized by movement of the anchor teeth. So we have the forward movement of the anchor teeth and the backward movement of the anterior teeth. In the minimum anchorage, or type C, the anchor unit should consume more than the majority, or at least 2/3 of the space available. As the name implies, the anchorage units are situated outside the oral cavity, or extraorally, and the structures that are most frequently used are the neck or the cervical region, as with the use of cervical pull headgear, the back of the head or the occiput, as with the use of occipital pull headgear, the forehead and chin, as with the use of face mask. The biggest disadvantage of extraoral anchorage is the apparent lack of patient cooperation. To have proper treatment, anchorage requirement must be considered at the time of treatment planning. And to plan anchorage, we need to consider several factors, including the number of teeth to be moved, as the greater the number of teeth being moved, the greater is the anchorage demand. Therefore, moving teeth in segments will decrease the load on the anchor units. The photo on the right, we can see that a closed coil spring is used to retract the canine alone, while on the left, the power chain is used to retract the whole anterior segment, which will increase the load on the anchor teeth, in this case, the second premolar and the molar. The second factor is the type of teeth to be moved. Teeth with large flat roots and or more than one root exert more load on the anchor teeth. Therefore, it is more difficult to move a canine as compared to an incisor, or to move a molar as compared to a premolar. And this is related to the root surface area. And we can see that the molars have the greatest root surface area. So they exert the greatest load on the anchor teeth if they are to be moved. The third factor is the type of tooth movement. Moving teeth bodily requires more force as compared to tipping the same teeth, which means that it will exert more load on the anchorage units. The fourth factor is the periodontal condition. Teeth with decreased bone support or that are periodontally compromised are easier to move as compared to healthy teeth that are attached to a strong periodontium. The last factor is the duration of tooth movement. The longer the duration of tooth movement, the greater the load on the anchor units. Another term is anchorage loss or loss of anchorage. It refers to tooth movement of anchoring unit during orthodontic treatment. It is undesirable in most of instances, and a common example is during overjet reduction, where teeth in the buccal segments move forward rather than those in the labial segment being retracted. There are several factors that can lead to loss of anchorage. The first is using heavy forces. The forces that are used to move the teeth should be light enough to exceed the threshold for tooth movement where planned, but below the threshold for movement of the anchorage units. When we use greater forces, we will not have an increase in tooth movement, but we will risk the movement of the anchoring teeth. The maxillary arch is more susceptible to anchorage loss as compared to the mandibular arch. And this is probably due to a combination of factors, but most particularly the density of bone. Patients with high angle or a vertical growth pattern are more likely to have loss of anchorage, and this can be attributed to lower bite forces and less occlusal interferences that occur in cases with reduced overbite, as well as they have more distally tipped molars. We can compare the angulation of molars on the left and right radiograph. We can see that on the left, in a patient with an increased vertical height or the vertical growth pattern, the molar is more distally tipped as compared to the one on the right where the molar is more upright. Placing a straight wire will lead to the rotation of the molar in a forward direction or loss of anchorage. Skeletal or absolute anchorage. It may be considered as an entity of its own or may be considered as a part of intraoral anchorage. It is described as absolute anchorage as there is no tooth movement except what was desired, so there is no unwanted tooth movement. This figure shows the outcome of using absolute anchorage, group A, group B, group C anchorage, and compare it to the pre-treatment position of the molar, which is the anchoring unit, and the canine, which is the tooth to be moved. We can see that with group A there is slight movement of the molar and more movement of the molar, which is the anchoring unit, in group B and still more in group C. While in absolute anchorage there is no forward movement of the molar at all, while the canine is being retracted more distally. There are several forms of skeletal anchorage devices, including endosseous implants and mini plates. Both of them have been used successfully for orthodontic anchorage and reinforcing anchorage as compared to extraoral anchorage. However, their clinical application is still limited. This one is an endosseous implant. These are mini plates. We can see that they come in different forms and shapes. There is an L-shaped, a Y-shaped, a T-shaped, and others. The main reason for the limited clinical application of endosseous implants and mini plates is that they require comprehensive surgical procedure for placement, and they are more difficult to remove after the completion of treatment, which makes the patient uncooperative during treatment, as well as they are more costly. Mini screws or temporary anchorage devices, TADs, are simpler alternatives to endosseous implants and mini plates. Their advantages include smaller size, simpler surgical placement. They can be immediately loaded without the need for lab work. They require easier removal after treatment, and they have much lower cost. The commonly used screw has three parts: the head, core, and thread. Most manufacturers give the outer diameter, which includes the width of the screw threads, in measurement. The diameter and thread length of the mini screw are the main features to consider when selecting mini screw. Some mini screws require drilling, and they are referred to as pre-drilling mini screws. They have cylindrical shape. Most of the current orthodontic mini screws are drill-free or self-drilling mini screw, and they are tapered. How to select the proper mini screw? First, depending on the length of the screw portion is ranging from 5 to 12 millimeters. The longer the mini screw, the better the mechanical stability, just like the dental prosthetic implant. But the longer the mini screw, the greater the potential for damage of the adjacent anatomical structures like roots, maxillary sinus, the nerve, etc. Usually 6 mm of screw depth is enough for the maxillary bone and 5 mm is enough for the mandible. However, we should always consider the depth of soft tissue when choosing the proper length of the mini screws. In case C, as we can see, there is thick soft tissue, thick gingiva ranging from 2 to 5 millimeters. The thickness has to be added to the total length of the mini screw to have 6 mm inserted inside the bone. And it is better to select the type of screw with collar portion, with a flat collar portion to minimize irritation to the soft tissue. Depending on the diameters of mini screws range from 1.2 to 2.7 millimeters, so they can be placed anywhere in the mouth. The choice depends on the interradicular distance, the quality of bone, and the site of placement. The thicker the mini screw, the greater becomes the mechanical retention, but also the greater the possibility for root contact. There are several anatomic structures that must be considered before placing a mini screw, including the roots of teeth, neurovascular bundles, the nerves and blood vessels, including that of the greater palatine and inferior dental nerve, and the bones and sinuses. Particular care needs to be taken when placing implants in the buccal and lingual alveolar bone and the paramedian areas of the palate because of the presence of the vital anatomic structures. In contrast, there are no critical anatomic structures in the mid-palatal region, the maxillary tuberosity, and the retromolar pad area, except for the incisive canal and the palate. There are several general guidelines that needs to be considered for the placement of mini screws. To select the proper horizontal position, we need to do proper assessment of the interdental distance, both clinically and radiographically, to avoid root damage. For the vertical position, coronally placed mini screw is likely to be on firm attached gingiva, which is the best, but the risk of root damage is increased because of the conical shape of the roots. So a compromised insertion point will be at the mucogingival junction. For the insertion angle, occlusogingivally, it is generally recommended to apically incline the insertion path to avoid possible root injuries and increase the cortical bone support. And a 45-degree angulation relative to the occlusal plane is considered acceptable. For the surgical procedures, for self-drilling mini screws, we have either one step or two steps. For the one step, we will administer anesthesia and then we will do driving of the implant. It is not recommended to have full-depth anesthesia. We will just inject few drops of anesthesia to anesthetize the soft tissue and the periosteum. For the two steps, we will administer anesthesia, then we will do initial penetration with a round burr, then we will complete driving of the implant. For the pre-drilling method, we will administer anesthesia, then we will do penetration with a round burr, then perform pilot drilling, and then driving of the implant. Mini screw driving is either done by engine-driven through the use of handpiece or hand-driven manually. It is safer to use hand driver to feel the resistance of mini screw driving torque. We should never give excessive force because if the mini screw is broken during driving, it may be a little troublesome to remove. This short video demonstrates some of the uses of mini screws. So we give anesthesia either by few drops injection or topical anesthesia, but we would prefer a few drops. A mini screw is placed and it can be immediately loaded with a closed coil spring to protract the molars in a forward direction. This is another use of mini screw for the intrusion of molars. Anesthesia, then driving the mini screw in. For intrusion of molars, we need to do both buccal and palatal mini screws. Then we can simply extend power chain and the molar will be intruded. This shows another use of mini screw, and here the force is exerted indirectly from the mini screw to a jig, sliding jig, that will distalize the molars. Then we have to place another screw in a different position, change the position of the mini screw to retract the remaining anterior segment. This video demonstrates the use of mini plates. We need to make incision, reflection of the periosteum, placement of the mini plate, and it's ready to use. Mini plates are safer because they are more away from the roots, but as we said, they are more expensive and require surgical procedure for insertion and removal. Mini screws have failure rate of up to 40% due to mini screw related factors, patient related factors, and management related factors. So the patients should be fully noticed, they should be fully informed of the possibility of failure before starting mini screw treatment. There are several possible complications with the use of mini screws, including soft tissue inflammation, ulceration, abscess, and coverage. Inflammation or an abscess is relatively rare if the mini screw is placed on the firm attached gingiva, and we said that it is recommended to place it on the keratinized attached gingiva, and the compromised position will be at the mucogingival junction. Ulceration, soft tissue coverage is associated with mini screws placed on or near the buccal frenum. The second complication is root damage. It usually happens with the pre-drilling method. It can be managed depending on the severity of the injury. Serious injury, including root perforation or fracture, is extremely rare in the drill-free system. The minor injuries on the cementum area can undergo spontaneous healing after removal of the mini screw. Another possible complication is root contact during tooth movement. The adjacent tooth movement toward the mini screw can result in mini screw root contact. These root contacts that are due to orthodontic tooth movement remain largely asymptomatic. Therefore, we should diagnose them clinically by having no movement of the teeth, excessive crown tipping toward the mini screw, and although it is rare, we may have mini screw loosening. Mini screw fracture remains another possible complication. However, it is rare if the diameter is greater than 1.5 mm, and especially if the mini screw is tapered. Removal of the bone around the mini screw thread is indicated in this case. Pain is relatively common with the placement of mini screws, but usually is not serious. It is of mild to moderate intensity. The pain related to mini screw operation comes from the nerve endings in the soft tissue and periosteum, not necessarily from the bone proper. Non-steroidal anti-inflammatory drugs for 2 days, for example paracetamol, following the procedure is sufficient to manage the post-operative pain in most patients. Excessive bleeding or numbness is not associated with mini screw placement on the tooth-bearing area or the mid-palate region. However, care should be taken not to injure the palatine neurovascular bundle. Thank you for listening.